Hello, everybody. My name is Gianluca Rovesti, and we are continuing in this series of webinars. For those of you that are not aware of this series, it's every Wednesday up to December 16. So we will have other opportunities. I'm not the only speaker actually, and this means that if you want to check for the program, you can do it on our website, admayora.eu, and check for the program that you can see for the title of the lecture, the speaker, the hour, if you are interested or not, etc. We will have, as usual, questions time at the end of the lecture. The lecture will be more or less 1 hour, a little bit less or more depending on how it will go. And you can use the chat function that you see on the right side of your screen to place the question that you'd like to be answered to, and I will be glad to take any question at the end of the lecture. We will have also a couple of advertisements during this lecture. I guarantee you that it's just a couple of minutes, so don't be worried. It will be short enough not to be very boring, but you know, TV has its own rules, and we should be aware of this. I'm sure that you already know. So time to go, and the topic of today's lecture is philosophy and techniques for minimally invasive osteosynthesis. It's a very important topic in my experience, because beyond the surgical technique that you are going to use for stabilizing fractures, of course, the first issue that every surgeon has to deal with is with fracture reduction and stabilization, because otherwise there is no technique that will be useful if this first phase won't be addressed properly. And this is not just about very big limbs with big muscles that, of course, represent an issue themselves, but also, and this I think it's a common experience, with segments where the muscle coverage is not that extensive, not that big, but nevertheless they represent a major issue and a major challenge for the surgeon to reduce properly those kind of fracture. I always had this kind of interest because I found myself in troubles so many times during my career, especially, of course, at the beginning of it. And I had that kind of reference. At that time, Fossum textbook was one of the reference textbooks. And those techniques are the ones that we can refer to. For example, the oblique technique, so inclination of the stumps, and then when we can reach their contact, we can push on them, and this I think is completely acceptable. And the leverage technique, I think this is still a good reduction technique. So putting a periosteal levator or some kind of leverage between the two stumps we may be able to use it to reduce the fracture, and I think this is good as well. But, for example, I was really disappointed by this suggestion because, of course, if we have fissures in the bone and we apply bone forceps on it, I don't think that circlage wire is capable to counteract the potential risk of this procedure that is fracturing, breaking of the bone, and the circlage wire is not able to counteract this option if you make pressure on the bone segment, on the bone stump, in order to distract it. Furthermore, you can easily realize that you need to be yourself very strong surgeon, or you need a very strong assistant in order to hold the bone segments, distract them, and keep them reduced until you will be able to stabilize the fracture, at least in a preliminary way. And so this is something that was not addressed by these figures. And of course, we can use bone forceps to hold the fracture reduced. But if you have even an early experience in fracture reduction, you can easily share with me the experience that usually just one forceps is not enough to hold the fracture reduced. So we need some forceps, and once you put 2-3 forceps on the fracture area to hold the fracture reduced, eventually, if we need, for example, to put a plate, we don't have room enough to put the plate in that area. So this can be a bit tricky, and this would be one of the major issues that we should be aware of. So we had to wait until this paper, 2003. It's a kind of old paper, but I still think that it was kind of corner paper, because it was the first paper I'm aware of that dealt with the current concepts in fracture reduction. So trying to establish some kind of principles that can be used for fracture reduction. And one of the most useful principles in my experience was the hanging limb technique. So preparing the limb with this kind of ring or hook or something similar, we could actually hang it to the ceiling or to the surgical lamp or whatever, in order to use the patient body as a distraction force to apply for reduce the fracture, for reducing the fracture. And of course, in some kind of segments, like radius ulna with a reduced muscle coverage, and with patients with a good body mass, we could be able to use this technique. But for example, when we had to deal with a patient with huge body mass, with huge muscles, or the body mass of the patient was too reduced to be able to use it as a distraction force, at least a significant one, we were in the situation that we needed a new idea, a new different way to approach the problem and try to work it out. And not always we need very fancy equipment in order to do that. Sometimes it's just a matter of strategy. The first and most, the simplest, I would say, way to do it is with iron pin. So when I have a very unstable fracture, and I don't want to start the reduction in such a way that I have to deal with this unstable fracture that will give me many troubles, I can just start stabilizing it in this way. Simple, straightforward IM pin that I can place in this way. Of course, this is tibia. Tibia, I think it's a nice bone segment to start with minimally invasive approach. And so if we use the IM pin technique, I can just use it at the beginning to realign the bone segments, but also to use it as a joystick. So I can insert in the proximal segment, use it as a joystick to realign the fracture, and then insert it in the distal segment to achieve good bone realignment. And this is the starting point to have that kind of alignment and help, intraoperative help, that will allow us to start with minimally invasive approach. What does it mean actually to try to have a minimally invasive approach? As you can see, minimally invasive means that we make shorter approaches than the standard one. This in the 90s would have been a surgical approach as long as the old tibia. And this is related to the fact that we suppose, and I think there is evidence of this from what was published and from biological tests, that if we preserve the connection between the bone segment and soft tissues, we are actually preserving the bone vasculature and blood supply. And this is a kind of keyword, because sometimes, especially in the past, we were more interested in having good pictures of postoperative X-rays with every single small piece in its place, but that bone took months to heal, or it even didn't. So this was a kind of lack of biological reactivity, biological activity. And this, in most cases, was due to the fact that surgical procedure was too aggressive, and the devascularized bone is no more bone. It's just hydroxyapatite something. So preservation on blood supplies is the key word to achieve a predictable, consistent, and active bone response. Tibia, as already told, is a nice segment to start with. So we can be able to perform this small proximal approach, not that small, but we don't have to be the smallest approach in the world, okay? As what is needed, okay? And this distal one, and we can slide the periosteal elevator underneath soft tissue on the craniomedial surface of the tibias, of course, where bone muscle coverage is reduced. And once we are with the bone realigned and hold in a stable way, we can just apply our synthesis means. That means what is going to stabilize the fracture. And as you can see, many times we don't need to perform a very complex, complicated procedure. This was one of the first procedure. Today, I probably would do it in a slightly different way, but IM pin is stabilizing and is counteracting bending forces. The plate that is the locked one, of course, is counteracting the axial compression forces and torsion forces. So I would say the principle is a good one, okay? The same can be used for radius. Although, of course, it is not possible to insert a IM pin in the radius, but we have a biossus segment, so we can insert this IM pin into the ulna. Not always easy. We should be really aware of the ulna conformation, because in most cases we take the risk of inserting the IM pin that is not IM, so it's out of the medullary canal. It's not always possible. For example, in small dogs, the medullary canal of the ulna is almost not present, so not always possible, but in the right patient, this can be very helpful. And again, we can have a proximal approach like this, distal approach like this, and this kind of overall stabilization that I think will help a lot from the biological point of view. And then circular fixators. As someone of you may know, I'm still a user of circular fixator, less than in the past, but still I use a circular fixator, not just because I'm personally convinced that is an excellent osteosynthesis method and technique, but also because it is a real powerful tool for fracture reduction. So a circular fixator in its basic configuration can be just a couple of rings connected by threaded bar. You easily realize that those threaded bar are very powerful distractor tools. So turning these nuts, we can increase this distance, and if we connect simply by one small K wire under tension on the first ring, the proximal fracture segment, and on the distal ring, the distal fracture segment, we can achieve something like that. This is an intraoperative picture of a tibia fracture. Distractor is a comminuted one, and we are not touching this area. But as you can easily realize, by simple distraction of the area, we achieve this more or less reduction of the fragments in their original position. And this is the principle of muscle ligamentotaxis. What does it mean? That when we have a fracture, we have a compression force that will displace the fracture segment with a centrifugal force toward the external area of the fracture area. when we leave the bone fragments connected to their muscle and ligaments and soft tissue connections, and we perform the opposite process, meaning that we are distracting the fracture, the soft tissue connection will get those fragments back, not exactly, not anatomically, but very close to their original area. And this is very helpful, especially if we are dealing with biological osteosynthesis. That means we are not intended to replace in a very anatomical fashion this fracture, but just functional. Of course, we are talking right now about diaphyseal or metaphyseal fracture. For articular joint fracture, the principle are slightly different. Not, it is feasible, but in a slightly different way. Okay, so this is an example. This is a case courtesy from Antonio Pozzi in Zurich University. So this picture showing half ring. Why half ring? Because in this way we have more room to play around. We have more space available to perform our surgical maneuver. So 1 K wire through the distal segment, 1 K wire through the proximal segment, under tension, distraction of the fracture, and once we have the fracture reduced, it is possible to perform a distal approach, a proximal approach, and then, of course, to stabilize, slide the plate underneath soft tissue and have this reduction and stabilization made like this. Is this possible just with plates or circular fixator? Now it is possible with linear fixators as well, provided that we have a linear fixator specifically designed for distraction or compression. That is the opposite side of the same principle. So if we connect this fixator to the bone and we have the fracture superimposed, we can have this device that we can use as a tool for distracting the fracture. And once we apply this micrometric distraction, there is no bone, no contracture, muscle contracture capable to resist this distraction, because this is a very, very powerful technique. Okay, so simple, but this can save us in specific situation. As often happens, we think that we invented something. We like to think that we are the most smart people in the world. We invented something. But if we look back to the past procedures, these are Renaissance drawing, Renaissance pictures. Renaissance in Italy means 1500th century, so 15th century or 16th century, something like that. If we see this, though it is a kind trivial technique, but nevertheless, we see that the principles for fracture reduction are already there, because we have the patient with a fracture of the upper limb. We have a means that is this one to counteract the translation of the patient, a stabilization mean that is this guy here, and the traction device that is this guy here. And if we see here, we have the same principle, adding the fact that we can set the traction. How big the force can we apply, and acting on the water content of this jar, of course, we can set the traction over there. Of course, this we can, we should something better for the seat, for the patient in this case, but let's say that the principles stay the same. And then we have a real machine for fracture reduction, meaning that this patient has the upper limb, upper extremity stabilized by this bar here, and then this belt on this area of the wrist will hold the elbow at 90 degrees, so that this belt on the forearm, on the radius ulna, can apply a distraction, a traction force in order to allow the cerusicus, that was a kind of a figure that was half barber and half surgeon, okay? So we have now a machine, and this is 16th century, okay? So we cannot say that we invented so much. Nowadays, on the human side, they have reduction beds, surgical beds, and for each patient and specific technique, they can plan the way to position the patient and to think about they can deal with this kind of surgical technique, so that it's planned beforehand, and we should be able more or less to do the same. Our major problem is fragment dislocation. We have this kind of superimposition of the bone segment due to muscle contraction. Okay, this is very normal. And with manual traction, we have the problem that it's tiring, not always powerful enough, of limited duration, unstable unless you have kind of Hulk as an assistant, and fatigues the patient and assistant muscles. The mechanical traction is not tiring for the surgeon, it's adjustable, is potentially of unlimited duration as usual when we are using powerful techniques. We should be completely aware that it can be dangerous as well. So we have to plan and to manage it in the proper way. So we need now to look to this in a different perspective. We need a different perspective, and we are dealing with it in just a couple of minutes. I'll be back. As promised, just a couple of minutes. So be back to our lecture. So we already talked about this technique. Is intraoperative skeletal traction. Okay, what do we need? Dedicated means surgical table means that not a specific table, but that is predisposed for the use of the fits of the accessories that we need during the procedure. A micrometric traction bar. Why? Because the traction bar is doing the job for us and is capable to hold the tension, the force applied to the fracture in a very consistent way. Stabilization belts that are used to stabilize the patient to the table in order not to slide it out of the table. A traction stirrup, we are dealing with this technique in a second, and a dynamometer. Why? Because I like to understand how much force I'm applying to the patient. So we need to define 2 points for the patient. The opposition point, that where are we going to apply the belts that are needed to stabilize the patient body to the table, because otherwise I'm just sliding the patient out of the table if it's not stabilized. And the anchorage point, where I'm going to apply the traction without damaging the patient. Okay, these are the two basic points. So first of all, the table as told, of course we have this table and I use it since 20 years, not the same version, of course, this is the last one, but let's say the important thing is we should be able to apply the kind of accessories that we need to perform the technique. Okay, this is the important thing. And of course the table is thought in order to allow, for example, the use of intraoperative fluoroscopy. I understand completely that fluoroscopy is not standard procedure in every veterinary OR, but I would say if you are willing to perform specific orthopedic procedure, I think that it's very, very helpful. Okay, so it's aimed for having this option for using fluoroscopy. Traction bar is simply a bar that can be lengthened, rotating this knob so that it will apply progressive distraction. And we can use this device. This is just a traction belt, and this is the traction stirrup. Let's check in detail how we can use them. Traction belt is the simplest device that we can use to apply traction. Very simple. This belt can be sterilized of autoclave, of course. It's important that we apply the nut on one side like that, and the other nut of the belt on the opposite side of the limb like this, in order to apply an even traction. If you apply just one of them, of the two on the same side, you are actually not applying an even traction force, straight traction force, but you are causing an angular deformity. Okay, and this of course is something that we don't want to achieve. So very simple, straightforward, but the problem is sometimes it can slip, especially if the fracture is very distal, or we cannot use it if you are dealing with a very proximal humerus and femur fracture. Why? Because we should transfer all the loads that we are applying with traction through too many joints. I don't want to damage the elbow, or I don't want to damage the carpus for reducing a fracture of the humerus. For those fractures that are proximal fractures, proximal segment fractures, or fractures when we have the traction belt that is slippery, it will slip away from its position, I prefer to use the traction stirrup. It is a very simple tool, but it's very useful in my experience. As you can see, it has two arms, okay? And this bolts over the extremities. The bolts are made as usual for everybody who knows circular fixation, for example. The screw is a pinched one, and the nut here. We can pass the K-wire through the pinched screw like this, and if we tighten the nut here, we will lock the K-wire into the pinched screw like this. So if we have the stirrup, we pass the K-wire through the bolts and through the bone, and then we lock the bolts, and then turning the nut here in the proximal part of the stirrup, here where the threaded bar is, we are actually tensioning the wire. Why is this important? Because if we don't tension the wire, it will bend during traction and it will cut through soft tissues, and we don't want this. We want it will stay very stable in order not to cut through soft tissue. If you are interested in going deeper in this topic, these are the first papers that we published down back in 2006. And then there is a dedicated issue of Veterinary Clinic of North America 2012, and the latest version of Veterinary Clinics of North America has two chapters, one general chapter on minimally invasive plate osteosynthesis, general principles, and one specific fracture for humerus fracture. Okay, if you are interested, you cannot find them, just ask me, email me, and I will send you the papers. Okay, so about the clinical use for radius ulnus, the standard use for radius ulnus is performed with the traction belt. As already mentioned, if you have a very distal fracture or the traction belt is slipping away from the limb, of course, you can use the traction stirrup as well. But generally speaking, we stabilize the patient with the belt, and with the belts in this way crossed over the thorax in order not to damage any other body structure. And then once we are ready for that and the traction is applied, we can cover this area in order to keep the surgical theater sterile. We will go in detail in this later on. Okay, so the overall situation is this one. And if we check it by fluoroscopy, but in most cases, you can just palpate the fracture reduction or make a small approach. I like small approaches. Why? Because they will allow me to check for reduction, and if I have the option to help during reduction by a small leverage or keeping soft tissues away from the middle of the fracture, this will help a lot. our objective should be not to apply too big loads, too big forces. We tested in our papers up to 25 kilogram force, more or less 250 newtons, okay? I would say no need for that. The standard force that we apply, even in big, in segments with big muscles, is 6-7 kilogram of force, 60-70 newtons. And this is because we don't need a huge force in order. If we need too much force, this means that we are something that is not working properly. So perform a small approach, a reduced approach, and check for that, okay? This is much safer for the patient. Once the stabilization is achieved and the reduction is achieved, and as you can see here, I perform as a small surgical approach to check for it, and we are able to stabilize the fracture with whatever surgical technique. In this case, for example, external fixator. But we are very easygoing in this phase. Why? Because the fracture is all very stable, and we don't need the assistant that is jerking because of the effort that is required. So as soon as we stabilize the fracture, please remember to release the traction in order not to causing any damage to the patient, okay? And at this point, whatever technique you like is good, okay? Whatever technique. This is not just for plating, not just for external fixation. It's whatever technique you like. For the femur, for example, okay, in this dog is a 10 kilograms dog with multiple traumas, hit by car, and this fracture of the right femur. As usual, we have segment superimposition, overlapping. This is very normal. And what we can do in order to restore the original functional physiological length, apply traction. How? In the femur and in the humerus, as already mentioned, we should use traction stirrup. How? So first of all, positioning the transcondylar K-wire. The K-wire can be applied in the condylar area, where I'm palpating the lateral fibula and the patella. The line that is connecting these 2 points in the middle of that line. And the K-wire should be perpendicular to the long axis of the femur. So we can get the K-wire on the opposite side of the condylar area of the femur without, of course, entering the joint. Okay? Once we have the K-wire positioned like this, very straightforward, simple procedure, we can apply at this point the stirrup and set it up, and very simple, very straightforward. So we have different sizes of this stirrup. You can select the correct size of the stirrup, not too small. The opening of the stirrup should be enough to stay, the arms should stay on both sides of the limb, but in the same time not too big. Why? Because we don't want undue interference with the fracture area. So we are connecting the K-wire to the arms of the stirrup, and once they are connected, we are tightening the nuts in order to stabilize the K-wire. Who knows the technique for circular external fixators knows that this is just standard procedure, okay? very straightforward, very simple technique. Okay, so tightening the knot, stabilizing the K-wire to the stirrup, and then we are just set. It will require about 10 minutes to be set up, but I guarantee you that we will gain a lot of time afterward. And then we have this knot here that we are turning and tightening, simply because in this way we are opening the arms of the stirrup. And opening the arms means to put the K-wire under tension. I want this K-wire will be under tension, because this means that it won't bend and it won't cut through soft tissue during traction. So now we are applying the traction bar to the surgical table, okay? And this, of course, is performed by an OR assistant. So we have the OR assistant that will apply the traction bar and the knee to this lateral bar of the table in the position that is suggested by the surgeon. There are specific positioning. We are not entering this topic because of the time that we don't have enough to enter any single technical detail. And then we can connect this, we can put the dynamometer. I like to use the dynamometer simply because I want to understand how big force I'm applying to the patient, and then I'm giving this sterile chain to the assistant. This is not sterile part now, and we are applying the chain to the stirrup. This is sterile part. Please be aware that I try to make the first tension by hand. Why? Because in this way I will remove the elastic component of the system, and it will be much easier to get direct distraction when I'm using the traction bar. And then I simply apply the traction as required, okay? As required. Of course, this will be performed by the external assistant, but under my direction as a surgeon. And when this should be done like not abruptly, but just a couple of kilograms, then we are waiting a couple of minutes, looking for soft tissue response, and then do it again up to when I'm happy of this. And then I will cover the not sterile part like this in order to be able to keep the surgical theater in a sterile way, and we can proceed with our procedure. If further distraction would be required, of course, the assistant can turn the knob again so that we will be able to achieve even more distraction if required. So nothing really special for this kind of osteosynthesis, simply the consideration that we were able to get back to the original length of the bone segment, simply applying this kind of bone distraction. That means that we are getting back to the same relationship that we had before the fracture. The fracture caused muscle contraction because the bone column was broken. And now we are getting back to the previous situation. We don't need, of course, here to achieve anatomical reduction. This is just a bridging plate, okay? Biological reduction, okay? Okay, again, couple of minutes of advertisement. I'll be back in a couple of minutes. Thank you. Okay, as promised, back in less of a couple of minutes, and we are going to proceed with the humerus technique. Okay, humerus is one of my preferred bone segments for fracture reduction with minimally invasive techniques. And I show you an example. There are many of them, even more complex, but I like to talk about principles in this webinar. And then, of course, we can have many variations of principles. So we had this patient, fracture of the homolateral femur and fracture of the contralateral shoulder. So we needed a very prompt return to weight bearing of this right front limb, because otherwise he was not in the condition to stand or to walk or everything. Okay, so positioning, as you can see here, this is just scrubbing positioning. Okay, this is not surgery position. So we hold the limb, prepare for scrubbing. This retention belt over the neck, protected with this padding, and over thorax protected with this padding. This is polyurethane padding. Here, please notice, when we have very delicate structure that may be damaged by the traction, as is the case of the neck, I put this support here in order to keep this belt elevated, in order to avoid any undue pressure on the neck. Okay, once the scrub is completed, we place the towels and apply the traction stirrup not to the humerus but to the ulna. Okay, in the straight direction of the axis of the humerus. This is useful to have all the full length and the medial epicondyle of the humerus specifically free of any interference. And this is especially important if we have to deal with a joint, an elbow fracture. Why? Because traction in the ulna will displace the ulna out of the fracture area, allowing us to perform an easier reduction of the condyle fragments. Okay? So, in this way, while I'm abducting the front limb of the dog, Why? Because for the humerus, I either perform, in this case, just medial approach, or in some cases, in specific fracture, in joint fracture, bilateral approach, but always starting from the medial side. Why? Because the medial epicondylar area is the direct continuation of the diaphyseal of the humerus. And it is straight, so I don't have to bend too much the plate. So I can apply the plate straight, and this will help me a lot for minimally invasive osteosynthesis procedure. So this is my approach. Traction stirrup on the elbow, on the ulna, down the elbow, in the same direction of the humerus axis, but on the ulna, okay? And this is the area. Please note two things. The first thing is there is a traction stirrup applied to the greater tuberosity of the humerus as well. Why? Because the shoulder doesn't have any bony attachment, just soft tissue, ligamentous attachment. And this means that if the fracture is not easily reducible, we are just displacing the shoulder, not reducing the fracture. In this way, if I stabilize the proximal part of the humerus with a second static traction stirrup, I will perform the distraction bone to bone, and this will help me a lot in achieving reduction of the fracture. And then I will start with this minimally invasive approach, just a few centimeters over the medial epicondyle, and I will start passing the periosteal elevator, and I will elevate soft tissue from the medial side of the humerus. And this is a true minimally invasive procedure. Of course, fluoroscopy in this case is needed because I'm checking the progression of the plate by fluoroscopy through the table that is radiolucent. And then I will lock the screws into the plate straight through soft tissues. So I will check where the hole in the plate is by fluoroscopy. I will make a stab incision. I will open it with a mosquito a little bit, and I will set the drill guide like this. And once I have the pre-drilling made, I will pass with the screw and the screwdriver straight through soft tissues. And I will lock the screw through soft tissue like this into the plate. Okay, so we have this approach for the diaphyseal fracture, and these small holes are just made for locking the screws into the plate like this. Is this an anatomical reduction? Of course not. Of course not. But this is a biological reduction. We didn't detach any vascular supply from the bone. And even though this was a young dog, so young patient is much easier than older diabetic or something like this patient, but nevertheless, this is what we can expect in a few weeks, okay? And this is very important if the patient needs an early weight bearing. Can be done with a bigger approach without fluoroscopy? I think so. But as I told before, why should I use, let's say, the worst technical choice if I can have the option to use a better one, okay? This is always matter of what is your objective. In those patients specifically, not in that case specifically for the reason that I told you, but for example, for joint, for articular fractures, I like to manage in this way with the jacket, protective jacket in the post-operative period. I perform a stabilization and osteosynthesis of a joint fracture. I want the dog to move the elbow, but I don't want him to put the limb on the ground because I'm scared that it can refracture. I use this jacket. I can set how much he can move his elbow or shoulder, whatever. And so for a couple of weeks, and then I can remove the jacket when I'm convinced that the bony callus is strong enough to protect the osteosynthesis, okay? We can use the traction stirrup manually as well. One of the standard example is fracture of the condyle in very young puppies. I'm convinced, and we are trying to publish this technique right now, that it is possible to reduce this fracture without opening the joint, the elbow joint, but just with an epicondylar, lateral epicondylar or medial, if the fracture is medial, approach like this, couple of centimeter, okay, just to check for the fracture area of the epicondyle. And then I will again apply the traction stirrup to the ulna, okay? Why it is so important in this case? Because the ulna will stay in the middle of the fracture of the elbow. If I apply the traction on the ulna, I will get two objectives. The first one, to realign the fracture. The second one, to move the ulna out of the fracture area. So it will much easier to get back the segment, the fracture segment to its original position. And if we can get this kind of fracture reduction, that is perfect fracture reduction, not more or less, okay? This should be perfect fracture reduction. So the fracture line should, in a sense, disappear. I can guarantee you that in 95% of the cases, also the intra-articular condyle fracture will be reduced if this epicondylar fracture is perfectly reduced. Of course, we don't need to have fragments here, okay? They should be one piece. And in this way, I will avoid to enter the joint, to enter the elbow, and this will reduce dramatically the aggressiveness. And then in very young puppies, I'm convinced that it's much better to use just K-wire technique to stabilize those fractures instead of using screws. If you are talking about adult patient, I completely agree that screw in the condyle is correct. If you are talking about 3, 4, 5 month puppies, I firmly think that just K-wires are much better. Why? Not because of the screw, but for the bone. The bone in 3, 4 month puppy is not strong enough, is not stiff enough to hold the screw in most cases. And this is the sequence. So first of all, epicondylar stabilization. This is a traction stirrup over here. We are tensioning, we are applying this traction, and then when we stabilize the epicondylar fracture, then we start putting the K-wire in a divergent fashion. Not too much, because the condyle is very small, usually, but slightly divergent fashion. Last case, when I use the traction stirrup, atraumatic manipulation of fracture stump. If we have a case like that, 4-month-old cat, dicondylar fracture, okay, like this. I hoped that it was monocondylar, but from the lateral projection, you can easily realize that it was dicondylar, okay, like this. This is not easy for two reasons, because the segments are very small. And the second one is because when you find yourself in surgery like this, and these are the two pieces of the condyles, do you think to be able to grab them with a bone holding forceps and bring them back to their original site? I don't think so. This is not my experience. You are crushing them. I don't want to touch them, or at least the less that is needed. And to do that, in order to achieve that, I pass a first 1 millimeter K-wire in the metaphyseal, distal metaphyseal area of the femur, 1 millimeter K-wire in the proximal metaphyseal area of the tibia, and then I connect them to the stirrups. Why? Because in this way, I can manipulate this bone stumps and performing the destruction required to bring the fragments in their place, back in their place, without touching this area, or just touching the area to push them, not to grab them, because if you grab them, you will crash them, okay? And then my preferred technique is to insert this 1 millimeter K-wire from the proximal side of the physis, of the distal physis of the femur, insert it through the medullary canal of the femur. Please note for this procedure, always extended hip. Why? Because if you are inserting the K-wire, with the flexed hip, you are getting the sciatic nerve. So always extended hip. I'm exiting in the dorsal part, and then the second K-wire on the other part of the physis. I will get like this, okay? I will just leave the tip of the K-wire out of the physis. I will get both K-wire from the proximal trochanteric area. I will reduce, just pushing smoothly, gently, the two parts of the condyles back in position, and I push back the K-wires in order to enter the 2 millimeter bone that we have in the condylar area on such a small patient. And then I will bring insert a 1.5 or 2 millimeter, depending on the size of the cat, threaded pin in the orthogonal direction through the condyles, femoral condyles, one more threaded pin in the proximal part, and then I will do a tying configuration like this, okay? Distal threaded pin, 2 K-wires exiting the trochanteric area, tying configuration, proximal trochanteric area for the proximal threaded pin. Why not in the middle? Because I don't want to take the risk to have a contracture of the quadriceps. The more you put things here in the middle through the quadriceps, the more risky is for quadriceps contracture. If you stay in the epicondylar area and in the trochanteric area, you don't take this risk, or at least it's very reduced. So this is post-op examination. Happy of the reduction, and we didn't crash the condyles, and usually the cat is dealing very nicely with that. this was a kind of 7-8 days after the procedure. The fixator, external fixator, is a radiolucent one in order to perform the radiographic rechecks without interference, as you can see from these X-rays. So radiolucent polylock external fixator, so that even when I have the clamps or the bar, that is carbon bar, over the fracture area, I can see through. And if everything goes smoothly and eventually, of course, we take advantage of the age of those patients, because they are healing machine if you don't damage their bone, okay? So if they are healing machine, we can think that 3-4 weeks we are at this point. That means we can remove the fixator, and usually the clinical outcome is very positive, is very good. So we can expect a good, very good clinical outcome. So here we are. This is my email address. If you have questions, of course, you can email me. Of course, now we have also the question time after advertisement. I'll be back in 2 minutes. Thank you. Okay, fine. Thank you for your patience. And now I'm available to take, I will be glad to take questions if any. Dr. Stanislav Vivra, thank you for your comment. Nice to meet you as well. Someone is typing, so waiting for the question. It will come up. And Andrew, thank you very much for your comment. Okay, Dr. Pardo says he wasn't able to hear the second part of the lecture. Please note that this webinar has been recorded, as all the webinar of the series. So if you for every reason wasn't able to attend, listen, or simply want to see it again, you can go to our YouTube channel, Admayora Educational. Here you have the channel YouTube channel link, and you can see the lecture, the recorded lecture again. And if you have doubts after seeing the lecture, even the recorded version of the lecture, you are welcome if you email me for any doubt. Okay. Okay, Rafa. De nada. Gracias. Okay. Aida Ramírez, Amazon Lectura. Amazing. I think this was automatic corrector issue. Okay, if it's an automatic correction issue, it's okay. No problem for that. I didn't get you immediately, but yeah, I understand. Okay. So just a few seconds more if you have any more questions. Otherwise, please remember that every Wednesday, next Wednesday, we will have an Italian webinar, and it will be on linear external fixation of appendicular skeleton. Supracutaneous locking plate is the question by Andrew Golachowski. Okay, Andrew is asking this because there is a Polish surgeon, a human one, who set a system that is called, now I have here the book, but I cannot recall the name. Okay, I have the book, CESPOL, nice, CESPOL system, CESPOL, and it uses the plate like an external fixator. But this is up to you. I mean, a locking plate, it's always being defined like an external fixator placed internally. Okay, so if you prefer to use your plate over the skin instead underneath the skin, this is up to you. If I have to use an external fixator, I would prefer to use an external fixator with the principle and with the technique and the hardware of the specific system. But it's up to you. The CESPOL system showed us that it is completely possible. Okay? So, no problem at all. It's just a matter of hardware, not of principles. Okay? If you respect the principles, you can use whatever hardware you like. Ciao Alberto, grazie per il commento. Okay, so I don't see any more questions. So I'd like to say you bye-bye. I hope to meet you again for the Wednesday webinars. And if you go to the Admayoro website, you can check the program of the webinars in order to check if there is something of interest for you. Okay? See you guys. Nice to meet you. Bye.